Welcome to the US ITI section webinar series on full arch implant rehabilitation. This webinar series will be composed of 5 episodes, and tonight we are addressing episode number 1 on treatment planning for full arch implant rehabilitations. And it is my pleasure to share this webinar series with an amazing panel composed of Dr. Tara Agalu from Los Angeles, California, Dr. Edmond Bedrosian from San Francisco, California, Dr. Renata Camino from Chapel Hill, North Carolina, Dr. Ricardo Mitrani from Mexico City, Mexico, Dr. Panos Papaspyridakos from Boston, Massachusetts, and Dr. Waldemar Polido from Indiana. And myself, I am also in Boston, Massachusetts, and we are very excited to share with you these 5 episodes. In this episode, we will address the edentulous patient, the dentofacial diagnosis, the implant prosthetic determinants, the implant number and distribution, loading protocols, restorative considerations, and we will wrap up with a summary and a Q&A. According to the UN WHO, the life expectancy in the US is close to 80 years old. And this is a significant improvement since 1950, where it was below 70, almost 67 years old. That means that our patients are living longer, and therefore our rehabilitations or implant rehabilitation in edentulous patient, they will also need to last longer. So Dr. Agalu, what is the scope of the problem with our population of edentulous patients?
Well, definitely the population is growing. As you can see, a large number of our patients are over 65, 9 million alone in the United States. And not only do we have issues with nutrition when we're edentulous, but just like I'm sure many patients come to you, Dr. Bedrosian, for looking for an improved quality of life. They want their functional limitations, they want their physical attributes to come back, and psychological and social disability. So really these edentulous people have a decreased quality of life, wouldn't you say? So I think that all of these things really bring about a negative self-perception. So we need to really address this whole scope of the problem. Dentulism consequences are vast, and you can see here, not only do we often have alveolar bone resorption, but we change our facial appearance, both the height and the overall appearance. The profile is significantly changed, like you can see in this picture here. Obviously, the patients have decreased masticatory function and bite force. You know, the pictures of eating the apple with implants is one that always captures our attention. Our patients want to be able to do that. And so really knowing that with complete dentures, they're very much less efficient. And then they modify their food choices. It's going to have a negative dietary impact because we all know that soft foods are not the most nutritious for our patients. And that's what we have to think about when we're talking to our edentulous patients. Not only that, but then we have to look at the risk factors. You know, even though we have all of these negative consequences from being edentulous, can we provide implants in a safe and effective manner? Are we going to be able to achieve implant stability and not have failure of our implants? Do our patients have systemic risk factors that are going to preclude us from being able to give them implant restorations? What about local factors? I talk about all the time that patients will have, you know, endo and retreat and apicoectomy and periodontal surgery. And then after all that fails in some circumstances, what are we left with? Is it an ideal site that our patients can really get implants and maintain, especially to support a full arch prosthesis? And then, of course, the surgical risk. Everybody is involved in implant treatment and most people in implant surgery today. And the surgical techniques are very different depending on who is the operator. Our patients have different bone quality and quantity. And of course, we have to choose our implants wisely because there are, hundreds of different manufacturers, maybe even thousands. And among those, so many different configurations and designs. And so we really have to make sure that what we're using, we really understand the science behind it and why we've chosen to use a particular implant. And then, of course, like we have all of our prosthodontists in the group are going to talk about things like prosthesis design and loading protocols, because I don't know about you all in the rest of the country and the world, but in Los Angeles, everybody wants everything right away, right now, immediately loaded, and they want it to look perfect. And oh, of course, they don't want it to cost very much either. So certainly, we're dealing with a lot of things that can be challenging for sure. So one place to start is really looking at some potential contraindications. Our patients are often at advanced age, especially when they're completely edentulous. Are they smokers? Do they have osteoporosis? And if so, are they taking medications like bisphosphonates and others? And are these contraindications to implant placement? Are they definitive contraindications, or are they just relative when we have to really just think about how we modify our treatment? Do they have diabetes or on steroids or other chemotherapeutic agents where their immune system is depressed or suppressed? And every day on TV and online, all the commercials are more and more about newer biologic immunocompromising medications for so many illnesses that maybe weren't even around when we first started practicing and thinking about implants. So it really changes our perspective in how we treat our patients and how we treatment plan. And so I think that Renata is going to address some of these to start out, to really, once we're past this initial medical history and medical issues, how do we treatment plan and how do we begin to answer the patient's questions?
Treatment planning full arch implant prosthesis can be extremely overwhelming due to the amount of considerations and parameters involved. Equally important as the dentofacial analysis is to understand who your patient is. Is your patient someone that has a full dentition but presents to you with terminal dentition? Or maybe it's someone that is partially edentulous with very few remaining teeth. Or what about the patient that was recently edentulated? Or maybe it's that one that has been edentulous for a long period of time. The reality is that patients in need of this type of prosthesis can exist across all age groups and present clinical characteristics that the clinician might not be used to seeing in the typical edentulous elderly patient. And while aesthetics can be a very subjective topic, in dentistry, we do have objective parameters that help guide us through this process. Identifying these references are commonly the first step in the diagnosis and treatment planning process. So if we can talk about 4 main clinical parameters in the treatment planning of this prosthesis, would be these 4. Following complete denture aesthetics, we always know that an incisal edge position is the starting point for any full mouth rehabilitation. Not only the vertical position for aesthetics, but also the horizontal position and the angulation for function and speech. The incorrect determination of the incisal edge can affect the maxillary occlusal plane, the vertical dimension of occlusion, and speech. Vertical restorative space must be a prosthetic requirement, but also, unfortunately, most of the times it's also a surgical commitment. It is very important that the clinician understands the different dimensions involved with different material and prosthesis designs. Then we have lip support, which actually influences if we can afford a fixed prosthesis. And if I could add to this parameter the importance of the lip length, thickness, and mobility, and understand that these parameters are not static, but very much dynamic. And also recognizing that there are differences that can range between ethnicity, age, and gender. My favorite is high smile line or excessive gingival display, because it is very easy to identify, but the secret truly lies in the diagnosis. Vidra, though, wrote a beautiful article where he actually describes the management and etiology of excessive gingival display in dentate patients and how it's important to recognize it because some of these presentations might need pre-prosthetic interventions prior to implant therapy. He mainly divides it in 4 categories: skeletal for patients that present with vertical maxillary excess, dental for patients that can present with dental alveolar extrusion, specifically angle class 2, division 2 malocclusion. For the gingival are patients with altered passive eruption. And labial would be patients with short hyperactive lead. It's important to understand that these are not exclusive to each other, and some of the times they can actually even present in combination with one another. So why are all of these parameters important? Because they are actually related to the prosthesis design. It's important for us as clinicians to understand what we can achieve and what we can actually do for our patients, and we can manage their expectations appropriately. So Panos, could you help us understand how would we evaluate this clinically?
So a dentulous patient will come to our office seeking implant consultation, a dentulous patient. Either they will have no prosthesis or they will have an immediate prosthesis, an interim denture or a definitive denture. The first thing we do, we need to assess the quality of the existing prosthesis for aesthetics, phonetics, vertical dimension, tooth position. More often than not, the existing prosthesis does not satisfy this criteria. So how do we assess what you previously described, Renata? The first thing we do is we have to establish tooth position, and that will be done with a flangeless setup. It's conventional removable prosthodontics fundamentals. We will set the teeth, removing the flange, especially because we want to assess the possibility of doing a fixed prosthesis. And that's how we will assess. If the existing prosthesis, and more often than not it may be acceptable, satisfies the aesthetic and phonetic criteria as well as the vertical dimension, then we just duplicate it. And on the duplicate, again, we remove the flange. By removing the flange, we will assess the lip support with phoros and intraorally and extraorally. And determine if we can move forward using the existing prosthesis as a radiographic template. Now, another important variable that we assess is the smile line assessment. And it can be either low, when the patient is smiling without the prosthesis and showing no gingiva, or it can be high. When the patient is smiling, the patient shows gingiva. And that is the tricky situation when we treat implanted dentulous patients because of the transition line. And what is the transition line? And how does the transition line relate to the smile line? These two are very closely interrelated. The transition line is in reality the prosthesis and tissue junction. It can be tooth colored, like you see on the photo on the left, or it can be gingiva colored when we have a large composite defect and we have to replace also the missing hard and soft tissues with pink ceramic or pink acrylic. And that area, the transition line, or else the prosthesis tissue junction, is height in space. And if the patient has a high smile line, it will show. Also keep in mind that the soft tissues are vascularized tissues. And this is a very dynamic situation that changes color all the time. So trying to simulate and match the patient's gingiva with the prosthetic gingiva is more often than not impossible. This tissue junction must also be flat or convex contour. We cannot have ridge laps because this height in space, as we said, will be impossible to keep clean. Finally, interart prosthetic space, and that is directly related to the tooth position because keep in mind, the edentulous patient comes to us to get teeth, not to get implants. Patients don't care about implants. They care about teeth and smile. So we have to put teeth and smile in the patient's face And once we have the tooth position on, then based on that, we retro-engineer the case, and this setup or the existing denture, if we assess that it is satisfactory, will become our radiographic template, and later, through the digital planning, will become our surgical template. So the last part of the equation is the interarch prosthetic space, and let's have edge rationale on how we assess interarch space based on the amount of hard and soft tissues missing and the size of the defect, whether it is a tooth defect or a composite defect.
Thank you very much, Panos. I think you and Renetta set the case up very nicely for us surgeons to also start talking a little bit about prosthetics. I think when we are referring patients to the oral maxillofacial surgeon, especially, we concentrate a lot on the surgical aspect, but we have to start with the end in mind, as both of you have so elegantly presented. So this schematic we kind of made up for our residents many years ago, and I think it works very well. So when we are evaluating a fully edentulous patient, what we try to do is we look at the occlusal plane, we establish an occlusal plane, and waiting for my little clicker to work here. There we go. So we established our occlusal plane. And if you look at the screen, on the left-hand side, we have a different patient than the right-hand side. So what's the difference between these two patients? The patient on the left-hand side has a limited space. Basically, they're missing the clinical crowns. And then the patient on the right-hand side has a much taller space. So they're missing a lot more than the clinical crown, and therefore they're missing teeth, bone, and gum. And that's a mouthful. So we've coined this term composite defect that we borrowed from surgery. And I think it makes a lot of sense. So it's very important to establish before we decide on what the surgical protocol is going to be, the final prosthesis. And I think it's very simple because there's only really two kinds of final prosthesis, either a tooth defect where the clinical crowns are replaced, or a composite defect where the clinical crowns as well as the hard and soft tissues that are missing are replaced. So once the surgeon establishes this, then they can continue on to coming up with the treatment plan on the surgical aspect. Then we go back with the restorative colleagues and meet and say, and take into consideration exactly what Panos mentioned before he handed over the podium to me, is the transition line, making sure that the transition line is hidden. And if it's a tooth-only defect, the transition line, whether it shows or not, doesn't matter, because the implants have to be in the perfect position. It's basically a tooth-only defect. Full arch is multiple single teeth implants. But if it's a composite defect, no matter how nice the matching of the pink acrylic or porcelain with its soft tissues is, the light will bounce off the junction and you will get a hairline black line. So the transition line has to be hidden. And once we've decided on the surgical approach and what the final process is going to be, the final consultation phase is the transition line, as Panos so nicely communicated.
Among the implant prosthetic determinants, anatomy, or the anatomy of the dentulous arch at the beginning of the treatment, is one of the most important ones. In this study, we have looked at the categorization of edentulous arches based on 100 cone beam CTs. And what we did here was to virtually plan implants for a rehabilitation up to the first molar. And then we were able to segment the maxillary anatomy and the mandibular anatomy into 4 categories: C1, C2, C3, and C4, where you can see C1 is where you can place implants along the arch without any anatomical obstruction. C2, where you have one unilateral side where you cannot place implants, and C3 is where you can only place implants mainly in the anterior, while C4 is just the severe resorb case. And a circle on the green, you see now that C1, C2, and C3 are the areas or the categories that they're more suitable for fixed rehabilitations. And if you look at in this study, 84 of the maxillary arches and 69% of the mandibular arches, they were somehow, at least from the vertical viewpoint, suitable for a fixed prosthesis. And then based on that, we were able to propose different implant prosthetic protocols, a little bit like guidelines where you can determine that your patient has a C1 or a C2 or C3, and then you go in this choosing what implant prosthetic protocols you want to have, whether it's a one piece, whether it's a segmented restoration, and the same for the C3 and the C4. And basically, this shows the importance of anatomy being one of the most predominant determinants for your implant prosthetic protocols. And now, of course, that can be corrected and modified. And I would like to ask Ed to show us from the surgical viewpoint, how is your rationale for selecting your implant prosthetic protocol?
Thank you very much, Herman. So basically, what we want to be able to do is to pick up the patient's two-dimensional panorex. This is certainly not the definitive diagnostic radiographic study, but it's the initial step in picking up the patient's panorex and being able to determine, at least preliminarily, what type of a surgical approach are we going to do? Axial implants, tilted implants, zygoma implants, grafting. What is it exactly that we're going to do? And once we've come up with that, then we go ahead and we confirm by further clinical examination and further radiographic 3D studies and such. So the mandible is pretty straightforward, as Herman just so nicely described. Basically, we have the mental foramina to worry about, and a lot of the cases are done intraforaminally in the mandibular symphysis. With the maxilla, because of the nose and the presence of the bilateral sinuses and the different pneumatization of the sinuses, becomes a little bit of a challenge. So to kind of make it an algorithm, what we did was we divided the maxilla into 3 sections. So zone 1 being the premaxilla, cuspid to cuspid, zone 2 being the bicuspid region, and zone 3 being the molar region. And as you can see here, this patient is missing clinical crowns only and has intact maxillary alveolar bony volume. So there's no missing bony volume. Well, things don't change, the zones don't change, or the teeth position that gives the patient soft tissue form does not change if the patient loses their entire alveolar ridge, as long as that alveolar ridge contour and form is replaced by the appropriate pink porcelain or acrylic. So the same zones is applied to the severely atrophic case, as in this case, cuspid to cuspid, bicuspid, and the molar region. So once so the absence or the presence of the zones determines the surgical protocol to be followed. So if you have all 3 zones present, then axial implants and placement of 6 implants, 2 in the anterior, 2 in the posterior, getting the biggest AP distribution to minimize or eliminate cantilevers. And then implant number 2 and number 5, basically the 5th and 6th implant, are placed in the cuspids. And in this configuration, as shown, we are addressing all the centric loads and all the lateral excursion loads, both on the implants and on along the arch length on the prosthesis. But what if the patient has zone 2 and 3, zone 1 and 2, but has limited zone 3? Well, certainly grafting and axial implants is again an option. But if you're going to immediately load the case, which is generally what the contemporary practices do, then we are kind of limited because you don't want to load the grafted portion of the case. And then if you leave that out of the immediate load provisional, then you have long cantilevers. If you don't, if you cut the cantilever, then you have a very short arch length. It's not aesthetic. So really grafting, I just included this because it is an option. But when we have a limited zone 2 and 3, then really what we consider is the tilted concept. So by tilting the posterior implants, paralleling the contour of the anterior maxillary sinus wall, then we are able to get the platform of the implant as far back as possible, lending the largest AP distribution, again, for the purposes of eliminating cantilevers. So zygoma implants or tilted implants are not done because they're sexy. It's done because we want to get the biggest AP distribution and eliminate cantilevers. So this is when we have limited zone 2 and no zone 3, and then it progresses to having only zone 1. So if there is no zone 2 and zone 3, no bicuspid molar support, well, we need to get the posterior support, and we recruit distal anchorage, which is the zygoma bone, hence the zygoma implant, allowing us to reach from the crest all the way to the bulk of bone that is available in the zygoma bone. Well, after this type of a resorption pattern, we have the most resorbed or fully resorbed ridge, and that's when there's total maxillary alveolar resorption, and basically we are left with the maxilla proper, where there is no bony volume. So hence the double zygoma or the quad zygoma concept for the rehabilitation of this group of patients.
So implant number. Implant number is directly related to what Ed was talking about regarding the size of the defect, if it is a tooth defect or if it is a composite defect. If it is a tooth defect and we aim to do a segmented rehabilitation, then we need 6 or more implants. If we have a composite defect and we want to establish a one-piece prosthesis, then we can place as few as 4 or 5 implants. And I know you're going to say this guy is Greek. What's up with the rhetorical questions? How many implants do we need? So there are all sorts of configurations. We can have as few as 4 implants with an axial or a tilted design. We can have 6 implants. We can have 8 implants. The implant number, as we said, is directly related to the prosthesis design, if it's going to be segmented or one piece, and if it is a tooth defect and we want to go with multiple segmented prosthesis, or if it is a composite defect and we want to go with pink ceramic or pink acrylic to replace missing soft tissues, so we can go with 4 or 5 implants. And since Waldemar was part of the group that dealt with assessing the evidence regarding the number of implants used for full arch implant rehabilitation in the recent 6th ITI consensus conference, I will give him the floor. Waldemar, how many implants do we need? What is the evidence?
Well, Panos, well, this is a great question. Like Ed pointed out, and also you brought it out before, and Herman explained, anatomy plays a big role. I was honored to be part of this group that did a big systematic review for the ITI Consensus Conference published in 2018, where we looked at the number of implants placed for a complete arch fixed prosthesis. And we asked the question, if the survival rates would differ between 5 or more or fewer than 5 supported implants. And this is a paper that turned out really good because I had some really good co-authors like Dean and especially Dr. Agallo as well. And we worked a lot on this paper that is getting some really good reviews. So when we looked at the manual, we overall added up to over 20,000 implants. 54 studies were with fewer than 5 implants. And we went all the way back to Brunemark first studies. So we looked at all types of studies that had at least 10 patients that had exactly the number of implants were clearly stated, not an average of implants, but exactly how many implants did they place per patient or per edentulous arch. So 41 studies looked at, reported on 4 implants, 12 studies reported on 3 implants, and 5 implants actually even reported on, 5 studies even reported on only 2 implants. But the most used configuration was with 4 implants, with the anterior implants in a parallel fashion and the posterior with a distally tilted. That was 28. And like almost like a tie here, 50-50, with the parallel between the mental frame and like Ed just mentioned, 26 studies. Now, very interesting was that the immediate loading was the most commonly used protocol, 41 out of this 54 studies. And the survival rates didn't change that much. Actually, 97 for the implants, 99 for the prostheses, with a follow-up up to 10 years with a median of 5.5 years. So in the mandible, like I just mentioned again, there is a similar configuration. 14 studies only actually went with 5 or more implants for the mandible, 10 with 5. So remember, the classic Brennemark style was 5 implants. That's how things started in the mandible, 6 in the maxilla, 5 in the mandible. And then there are reports on 6 implants, only 3 reports, and only 1 report for the mandible with 8 implants. Again, the parallelly placed configuration was the most widely used. And when more than 5 implants were placed, rarely they would use a posterior distally tilted implant. Immediate loading again, 9 and 7 unconventional, and survival rates were pretty high. So overall for the man, we can say if we are using 4 implants, the distally tilted ones and anterior parallel placed is the most widely configuration. How about in the maxilla though? So when we look at the maxilla, we looked at over 10,000 implants, and 26 studies actually reported on fewer than 5 implants, being 22 out of 26 with 4 implants, and only 3 with 3 implants, and only 1 with 2 implants. So by far, 4 implants are widely reported on the literature. Again, when we use 4 implants, or when the authors that reported on this papers use 4 implants, the anterior parallel and the 2 posterior distally tilted, like you see in this illustration, was the most widely used configuration. Again, immediate loading in 25 out of the 26 studies, and even all with provisional prosthesis, important to mention. And survival of the implants were 97%, and after prosthesis, 98%, and that is the final prosthesis. So again, a median follow-up of 5.5 years. Interesting though, is that in the maxilla, 24 studies had 5 or more implants. So it's almost a tie. Out of the 24, 20 were 6 implants. So 6 implants seems to be the preferred configuration for the maxilla. Of course, we know all the anatomical implications, like I just mentioned, posterior maxilla, less bone, more bone, zones 3, zone 2 even. So the zone 1 is actually the most widely reported on. 2 studies reported on 7 implants, 2 studies reported on 8 implants. There's actually a few studies reported on more than 8 implants, which is, very rarely or necessary actually. We can discuss that as well at the end. Again, the parallel, when 5 or more implants were used, the parallel configuration was the most widely used, but still right next to it at 10, we had anterior parallel and posteriorly distally tilted. Immediate loading again, the widely used configuration is 18. Papers out of 24 reported on that, and the survival was very similar, 95 to 98% for the prosthesis. Interesting though, the median follow-up here was higher. So people have been doing 6 implants or more for longer than 4 implants. So we started with 6, maybe 8, and then with time we're now reducing it to 4. So we have a longer follow-up on this 6 implants configuration. So as an overview, there is actually no significant difference in survival rates for a fixed prosthesis for both maxilla or mandible between less than 5, let's say 4, or more than 5, or actually 6 implants with a median follow-up of 8 years. The most reported configurations were when using 4 implants, the tilted implants, distally tilted, and when 5 or more, the parallel configuration. So this is what we do. So as an overview, there's actually the use of fewer than 5 or 4 or more is supported by evidence. I can easily say clinically, it's not a scientific, but clinically 4 implants for the maxillar mandible versus 6 for the maxillar mandible, they would work very similarly. So many other factors have to be taken into consideration when planning this. The need for graft, the need for tilt, cantilever, anatomy, loading protocols, opposite arch, a lot of prosthetic issues, and of course, all the topics that you guys discussed before I mentioned the number of implants. So interesting though is that distribution seems to be very, very important. So it's not a big thing to put 4 implants right at front, but distribute the implants. So Pendus, what do you think about distribution? Do you think that is a really important thing? More important, I would say, than the number of implants. So what do you think about the distribution of the implants, the necessary distribution?
Thank you, Waldemar, for showing us the evidence, the current evidence regarding the number, and connecting this with the distribution of the implants. And this clearly illustrates that the distribution plays a more significant role than the actual number of the implants. And why does the distribution of the implants, or anterior-posterior spread, AP spread as we call it, play a role? Cantilevers. It has been shown, and so many longitudinal studies have shown, that adequate AP spread will definitively and evidently reduce technical complications and overloading of the implants. We started off placing the traditional Brannemark style 5 implants interforaminally, and we evolved trying to, with grafting procedures or with tilting implants, or even being able to place axial implants further back, and found out that the anterior-posterior spread is very important for the structural integrity of the rehabilitation and the reduction of the technical complications, which are time-dependent. The longer a prosthesis is in the mouth, the more the chances that the material will fatigue and we will have technical and mechanical complications. There, in the 90s, in the early 90s, Charlie English had published an article that was proposing, with some empirical observations, that the cantilever length can be 1.5 times the anterior-posterior spread, but the world was much different in the early 90s of implantology when Charlie English came up with that. We know that now we have longitudinal studies that show that this is not true anymore. And I would agree with the available literature that is now clear on the fact that we have to minimize cantilevers, and cantilever has to be less than the AP spread. And that will bring us to the next topic, which is tilted implant treatment concept. And why do we tilt implants? In order to gain anterior-posterior spread. The concept was developed in the early 2000s, and that was to reduce the cantilevers that were associated with complications, and of course to reduce the morbidity that was associated with extensive GPR, because what is the most common situation that we will see? Pneumatized sinuses in the maxilla and extremely resolved posterior mandible. So grafting procedures may work, especially maxillary sinus elevation. Grafting the posterior mandible is more challenging. It can be done, but this is associated with morbidity, and it doesn't have the 96% survival rate that an implant might have in the long run. So in order to reduce the morbidity and associated with the grafting procedures and the technical complications associated with cantilevers, tilting of the implants to gain more AP spread was introduced. Now, we have, again, the current scientific evidence from the recent 6th ITI consensus conference that was held in Amsterdam. And the evidence is clear again, that tilted implant survival rates have no difference from axial implants. The prosthesis survival rates supported by tilted implants and axial implants are no different than the conventionally placed axial implants. And patient satisfaction is also enhanced when extreme bone grafting procedures are avoided. So can we intentionally tilt implants? Yes, we can intentionally tilt implants, and it was shown that the loading of axial versus loading of tilted implants did not affect the implant survival. The recent 6th ITI consensus conference, as I mentioned, came up also with clinical guidelines for clinicians. And that was based on all the available evidence, coupled with expert clinicians' opinions that perform these procedures daily. And this is a sum up of the whole discussion that we have right now, that the use of minimum 4 implants, but appropriately distributed to support the one-piece full arch prosthesis is recommended. And we tilt implants distally, intentionally, to improve the biomechanical stability of the prosthesis and reduce the cantilevers that we know that are directly related with technical complications. However, as we discussed regarding the implant number, we have to, when we treatment plan a case, we have to decide how many implants are we going to place and why. We have to place as few as possible, but as many as necessary, because the impact of an implant loss on the prosthesis support, if we have a reduced number of implants, cannot be avoided, especially if it is a distal one. So that has to be taken into consideration. Excuse me, the light went off. When we decide how many implants we're going to place.
Now, when it comes to the loading protocols, the last ITI consensus conference, we proposed a new way of looking at loading protocols, which is combining with placement protocols. And here you have the new classification that we will be using for addressing in the current and upcoming episodes for edentulous patients. So basically, what we have discussed here is the combination of the placement type 1, 2, and 3, or 4 with a type of loading, immediate, early, and conventional. And therefore, when an immediate placement with immediate loading, we will be referring as a 1A group, or a late placement or implant placed in a heel bone with conventional loading on a 4C group. And this is an important element to distinguish the type of placement and loading protocol as it affects the survival rate depending on which group you are addressing. But when it comes to the loading protocols, I think this is overall a question of the treatment sequence. And I would like to show you this schematic design on the main five sequence steps that we will all go through in treating these patients. You will need to come up with your planning. You will need to come up with a plan for your transitional prosthesis, whether you extract the remaining teeth or whether you are delivering a transition prosthesis after the implant placement. Then you need to have strategies for placing your implants or do the bone grafting procedures that you may need. We all go through the phases of loading a provisional onto the implants, whether it's immediate, delayed, or early. And then the final step is the definitive prosthesis. So in this context, these 5 phases of the treatment, they need to be well represented in our treatment planning exercise. Not only just the implant number and distribution, but all these 5 phases should be somehow discussed and have in mind in treating these patients. So I'll show you this table. It's a little bit busy, but you can have here that you have basically 2 different possibilities. We are treating an edentulous patient that comes to you already edentulated, or you are treating a patient with a failing dentition. And then if you look at the 5 phases, you have now the type 4 delayed placement with a delayed loading, a type 4C where you're going to use mini implants to retain a fixed prosthesis but not loading the real implants, delayed placement with immediate loading, or moving now on the side of the fixed transitional prosthesis of a failing dentition, immediate placement and immediate loading, type 1A. Stage approach, meaning you keep some teeth, place the implants, and those teeth hold the prosthesis, or do the extractions, give the patient a denture, place the implant, will be for the type 4C for delayed placement and delayed loading. And all that are the options that we will address in the coming episodes of this webinar series in detail, with clinical tips and exercises and clinical cases to demonstrate these phases. So Panos, what does the evidence show for immediate loading in fully edentulous patients?
So that was the question in the previous ITI consensus conference held back in 2013. and we were part of the team that analyzed the available scientific evidence back then. And what we found out was that we analyzed more than 13,000 implants. And we found out that the loading protocol, whether it is a conventional one, which means applying the load after 2 months of integration, an early loading, which is from the first week to the 6th week, or an immediate loading protocol, which is within the first week after the implant placement, and whether it was maxilla or mandible did not make any difference, yielded more than 90% survival rate up to the first year. And we analyzed the data up to the first year because after the implants integrate, the effect of the loading protocol on the implant survival stops to exist. We were pleasantly surprised with the outcome of the literature review that we conducted, with more than 99.5% was the implant survival. And that confirms the clinical application of immediate loading protocols daily in our private practice.
All right. Well, I've been amazed by the body of evidence and information that all my colleagues have shared so far, and it is now my turn to, I guess, share some ideas regarding what is it that we look into when we actually decide on a restorative design. If you think about it, what we've heard so far is mainly considerations regarding fixed type of prostheses. And whether a patient presents with a terminal dentition or a patient presents with an edentulated ridge or a couple of ridges chronically, we all know that sometimes we end up offering a removable solution as well. And so years ago, we put together this chart, which is part of an article that's published, and I'd be more than happy to send the link. This is part of an article that lives in Spear Digest. So we look at these 5 different elements, and while it is not a linear, if you will, review or equation, it is very important for us to realize the intricacies and the connections between all of these elements. So, of course, on the one hand, when it says location, we're actually looking at a couple of things here. We're looking at how the patient presents. If we're going to be treating only the maxillary arch, only the mandibular arch, or both arches, but also, I guess, qualitatively and quantitatively, how the patient presents, whether the patient has a so-called terminal dentition, whether the patient has an edentulated situation, or believe it or not, in private practice, we also tend to see many patients that have what we call ill-conceived designs, which means that the previous team of clinicians presented some type of prosthesis that was ill-conceived, in the sense that a patient was not truly looked into in the sense of providing the right type of solution. Secondly, I think it's very important for us to assess the etiology, both what is causing the future edentulism or what has caused the edentulism. And I guess this relates essentially to, the type of defect that we will have, just like Ed showed and Panos showed, which ultimately also has to somehow be linked with what we call the condition related to what we call the LTR condition, which means the correlation between the lifted tooth and the ridge. And I will go into this momentarily, but the bottom line is we look at these 3 clinical parameters, if you will, but we also have to consider some personal items from the patient's end. Has to do with their behavior, their level of compliance, and of course, their financial capabilities. And so what I want to do briefly is just walk you through this chart here that allows us to see what basically guides our decision process, whether to keep or to maintain what could be the remaining teeth in a patient's arch. So granted, if a patient has advanced structural damage, no ferrule, a lot of recurrent decay beyond the gum line, et cetera, of course, we're going to be removing those teeth. If a patient has advanced periodontal disease, lack of support, a lot of mobility. Of course, we're also eventually going to be removing those teeth. But as you all know, sometimes we decide to remove teeth, even in situations which there's not clear-cut structural damage, nor advanced periodontal disease. And so with this in mind, we'll look at these three different variables, which have to do with the amount of teeth, their distribution, and the dentogingival or dentofacial aesthetic risk, which boils down to the following. So if our distribution is unfavorable, let's say we have unilateral location or distribution of these teeth, well, it makes not much sense to keep, so we're extracting. But if we have a bilateral symmetric distribution, let's say we have a couple of canines which are intact. Needless to say, we have canines and first molars that are intact. Of course, we would consider maintaining them. And so again, the way this correlates potentially with the dentofacial potential risk, and Renata spoke about lip mobility and the importance of assessing lip mobility. And so once again, how all these different elements intertwine. If we have a high risk aesthetically patient, and again, also Ed alluded to the fact of the transition line, if this is going to become an issue, keeping some teeth and placing some implants, we're better off removing them and placing the implants. But if and when we have enough soft and hard tissues to keep some teeth and to be able to camouflage the end result, then we're better off maintaining it. And obviously I went very fast through these charts here that normally take much longer to assess, but I hope they give you the gist of the importance of us to assess the remaining teeth as part of our treatment planning protocol. And lastly, I just want to basically walk you through the last part of this chart, if you will, which connects what we at Spear teach as the four fundamental aspects of treatment planning, which is the aesthetic, functional, structure, and biologic aspects of the rehabilitation. And lastly, I want to quickly, for the last couple of minutes, just walk you through this classification that we published a couple of years ago. And granted, every single clinician utilizes a different classification. And you know, this is nothing new under the sun, right? You could go back to Siebert's classification to assess a ridge defect. You could look at what Misch classified. You could look at what Bidra classified. And many of you have described all these different classifications in the past. What we did with Polini and Jack Goldberg and Morton some years ago is we looked at the four potential situations, if you will. If you look at the class one, what we call the LTR class one, is what Ed Bedrosian refers as the tooth defect, right? So it's going to be an all-white restoration. Now, the importance, or I guess the added value of this classification, if you will, is that we're not only looking at potential fixed type of restorations, but we're assessing the potential need for removable. We're also assessing the potential risk of a high lip mobility that will, once again, will not allow to conceal that transition line. And the reason why I think this is important, and you know, most of you guys here in ITI are incredibly academic and everybody follows these academic protocols, but the reality is that out there in practice, we see a lot of people, how should I say, you know, going through excessive treatment when it's not needed. In other words, removing excessive bone, removing teeth when we could actually do a very good job keeping them. And so what this classification does is that it allows for us to communicate to the patient what's going to be the price to pay if and when we need to remove excess bone to accommodate for a fixed hybrid when we have a lot of bone. And so it then becomes an issue that the patient may decide on doing so. But to me as a clinician, as an educator, it's incredibly important that we are able to put all these elements within our treatment planning discussion, because only this way can we truly provide a solution which everybody is potentially comfortable. And again, I don't want to spend more time talking about this. Maybe we can do this during the Q&A, but I think it's fundamental for us as clinicians, as restorative dentists and surgeons and dental technicians to have these discussions, because ultimately, I believe that without these communication and these conversations, you know, we can potentially incur in making either prosthetic, surgical, or technical mistakes. So with that, I think I'm gonna now hand it on to Ed who's going to, again, entice us as far as the tooth-only defect, what he describes here.
Yeah, thank you very much, everyone. I think everyone summarized the treatment planning essentials or absolutes. There's not too many rules, but they're pretty dogmatic. And if I can just paraphrase something, we all talked about the arch length. Obviously, you want to have implants along the arch length, so there's no cantilevers. And we talk about removable versus fixed. I wonder if it might be a good idea to, instead of talking about removable or fixed, talk about whether the prosthesis is implant supported or tissue supported. Okay, because it could be removable and it could be either implant supported or tissue supported. So in a tooth only defect, a patient who is missing their clinical crowns only, then placement of implants along the arch length, whether it's 4 or 8 or 6, I really don't care. But the final prosthesis is a white prosthesis, zirconia, ceramic to metal, porcelain, whatever it is, it's a white prosthesis. So that's for a tooth only defect. So I think this is pretty straightforward. On the composite defect patient, the patient who is missing their teeth, bone, and gum, then we have to add the pink component, right? Because if we go ahead with a white bridge here, then they're going to look like a little hamster. So that's not so that's why we go to a pink and white prosthesis. But this pink and white prosthesis, again, with implants distributed along the arch length, is a palatless, fixed, implant supported prosthesis. So every implant prosthesis is implant retained, right? Even a locator is implant retained, right? But the big deal is it implant supported or tissue supported? So this fixed hybrid for the composite defect patient, or the fixed implant complete denture, the FICD is the prosthodontic glossary term for it, which needs to be a little bit updated, but that is what it is again pretty clear. What becomes a little bit muggy is this one. So this is a overdenture, but an overdenture by itself is like saying extraction. It means something, but it's not very specific. This is an implant supported overdenture as opposed to a tissue supported overdenture. And the difference is that it's basically a hybrid, a convertible hybrid. The framework stays in the patient's mouth, but the teeth can be removed. Hence, some people call it a fixed detachable. It's fixed and it behaves like a fixed prosthesis because it's an implant supported prosthesis, but it's detachable or removable like a denture. So, but implant supported overdenture has pretty specific criteria, right? It has to have a framework that has implants distributed along the arch length of the framework, so there's no cantilevers. It has to have a secondary casting, as you see in here. And I particularly have picked this one. This is the Marius bridge. The reason why I picked this one, although very rarely used because it's extremely technically difficult to make, but I picked it because the tolerance between the secondary casting inside the overdenture and the framework is less than 8 microns. So when it's placed in the mouth and then the locking mechanisms are locked, this thing behaves for the patient, or the patient perceives it as immobile as a hybrid would be. So this is an implant supported overdenture for a composite defect patient, if removable was your choice for whatever reason. And the previous slide that we showed, the fixed hybrid or FICD is the second choice. So for the surgeons, again, who are watching this presentation, we really have only 2 kinds of prosthesis that's practical: the tooth-only white for the tooth-only defect, and the pink and white or the hybrid for a composite defect patient. And this is a pretty technical thing to make. You need a very skilled laboratory technician, because you have a secondary casting onto a primary casting and then a latching mechanism. There's a lot of protocols. And just to hand over the alternative, why I like to talk about whether it's implant supported or tissue supported, if you take this bar off, you have 4 implants, let's say in positions 3, 7, 10, and 14, and you place 4 locators on it, and put back a U-shaped bridge, your biomechanics are all over the place. As Panos said earlier, tilted implants behave the same as axial implants under function for only one reason, and that reason is they're cross-arch splinted. So if you take these 4 implants and replace them with locators with a palatless overdenture, then it becomes a tissue-supported overdenture designed as a implant-supported overdenture. So we need a palate on when it's not cross-arch splinted, because the palate is the primary support in a tissue-supported prosthesis. So if I can just ask Panos, who is a prosthodontist, and I as a surgeon will back off for a second, explain this better.
I mean, it was beautifully illustrated by you and Ricardo, all the concepts that we take into consideration when we plan the case. And it leaves us with the final part of the equation, the prosthetic space. And I could kill the audience with numbers. What is the minimum amount of number for a metal resin restoration? What is the minimum amount of number for a metal ceramic? Or what is the minimum amount for a zirconia bridge? But as a prosthodontist, my take-home message for every clinician that tomorrow will do a consult for a edentulous patient and will treatment plan the case, after discussing all this beautiful illustrated sequence of thoughts during treatment planning, will be this. Tooth position is key, because patients come to us to get teeth and smile, not 4 implants or 6 implants or 8 implants or 1 trick pony, always placing 4 implants and a zirconia bridge. So tooth position is key. This will determine if we have a tooth defect, like Ed showed, or a composite defect, or we need to add pink. And never fit the patient to the prosthesis, which means do not do 1 trick pony prosthesis for every patient. Fit the prosthesis to the patient. If the patient is a tooth defect, do not cut bone and place pink and ceramic and eradicate all the available bone just to do this 15 millimeters of available space to do the zirconia bridge. Fit the prosthesis to the patient. How much space do we have? Can we work as prosthodontists and increase the vertical? Can we change the tooth position? Can we do some plasty if we have to? Every case is different. So that's the take-home message that I have to give, instead of giving out numbers, because we could argue for hours what is the minimum number for a zirconia or a metal ceramic cemented or screw retained.
Now, Panos, that's a very interesting comment. And I want to ask, I mean, as you can see, we have a panelist of surgeons and prosthodontics. When it comes to treating a tooth-only prosthesis or a pink white approach, it appears that, you know, it's a much more popular approach to have a pink and teeth. And it's not necessarily, as you said, guided by the anatomy. It's mainly guided because other technical limitations that there are with the white or tooth-only defect, which is what Ed said at the beginning, that when you are doing that approach, the implant needs to be placed exactly in a prosthetic position. You can't just, you know, guess on the location of the implant, because then it has aesthetic consequences. Do you all feel that we are favoring a pink-white approach for that very same reason?
I think in Ricardo's flow chart, at the first one on the lower right corner, he had the dollars in there. I think in private practice, I mean, I 110% agree with Panos. You fit the prosthesis to the patient. However, surgically, whether it's a tilted case, axial case, zygoma case, the surgical fee doesn't change whether you have a white bridge or a hybrid. The intensity of the surgery changes, obviously, if you have a white bridge, because as you said, the implants have to be in the perfect position, but the surgical fee doesn't change. There's a dramatic difference in the prosthetic fee between a white bridge and a hybrid. So I totally agree with Panos. Patient comes in, let's say they have cervical caries with no bone loss, so all the teeth are atraumatically removed, and by the book, they are a white tooth-only prosthesis, but they can't afford the prosthetic fee. So my always my recommendation for alveoplasty has been, after presenting the anatomy and the appropriate prosthesis as described by Panos, then you have to give the patient informed consent. Mrs. Jones, if we were to do an alveoplasty and convert the prosthesis to a hybrid, then the prosthetic fee can be reduced by a third or whatever it is. So I think after informed consent, the changing of the prosthesis from a white to a white and pink is appropriate, but to come in as a one-trick pony, that was popularized by chains that do only one type of prosthesis, and I don't want our colleagues to think that every patient who walks in gets a standardized 13 millimeter alveoplasty.
I think this is a great point, because I agree with you. It's that it sometimes, most of the times, is a cost issue that comes from the prosthetic place. In many places out of the US, this is not that much of a difference. So we don't want to go talk about cost and lab fees and all that kind of stuff here, but in many countries, this is not the case. In Europe, in South America, it's not the case. So we can actually propose to patients a like white or slightly small pink than actually doing a big alveoloplasty, because what we're actually doing when doing alveoloplasty, we're accelerating bone resorption. That's what's happening. We're accelerating bone resorption, and we're creating a patient that 10, 15, 20 years from now, we may be placing zygomas or grafting. And then that's, although I love doing that, but we have to think about the patient first, no question. But that's an interesting discussion that may require another episode just to talk about that, Dr. Gallucci.
Oh, we have an episode on implant placement protocols, and I can guarantee the audience that episode 3 will address thoroughly this topic. So
Oh, thank you everyone for helping us understand the parameters that guide the decision-making process for the clinician. However, we cannot forget that the patient also plays a key role in this decision. Devan said, the dentist should meet the mind of the patient before they meet the mouth of the patient. And as we talked about, there is definitely a psychological effect and an emotional component of a patient losing their teeth. I can certainly not imagine if someone tells me I'm going to lose my teeth tomorrow. So with that in mind, we can understand why most of the patients that come into our practices ask for fixed prosthesis. However, I think we have all agreed that it's our responsibility to educate the patient, discuss the risk and long-term prognosis of our treatments. And part of this discussion should address the maintenance. We know there are different maintenance protocols based on prosthesis design, material, and opposing arch. We should really discuss with our patients not only the initial cost of the restoration, there is also a long-term cost for repair and replacement. So this is something we need to address and communicate efficiently with the patient. And of course, we cannot hide the cost. Most of the cost is gonna be really a concern for most of our patients. It can vary widely between the lab we use, the material design, and the prosthesis choice, but it is there. We cannot hide it. And last but not least is the complication rate. So while the complication rate in full arch prosthesis presents at a small percentage, there are still many of them. And regardless of the prosthesis the patient is wearing, the most reported complication is still related, unfortunately, to the dental material. So it's important to have all of these considerations when we're treatment planning for these rehabilitations. I don't know if anyone in the panel would like to add anything to this slide.
I think that this slide summarizes the discussion, and I think you wrapped it nicely with the comment that it's not on your treatment planning exercise, not what we are going to do, not what we can do, not what the anatomy allow us to do, or the number of implants, is how we can get that patient for the long term with a stable restoration. And I think that's why I like this slide here. Yes, all those technical aspects that we have discussed before are essential for us clinicians to, treat the patient with a certain number of implants and a certain number of materials. But when you wrap up all this into the perspective of the individual, of the patient, I think that what the patients really like, and we would all like, is to have long-term stable outcomes that we don't need to go back and do. And that is what I think we should be guiding our treatment plan on.
Herman, on the preference that Renetta just mentioned, maybe the audience would be happy to know that about 18 years ago, I think Professor Van Steenberg from Belgium published a very interesting article. Patients who are existing, although I have a bias to fixed, I mean, I will admit that right away. But his research interviewed patients, and if you were a pre-existing edentulous patient with a denture, as opposed to a terminal dentition patient who's never experienced a removable prosthesis, then when immediately loaded, the terminal dentition patients preferred the fixed. And some of the, I think it was like between 30 or 40% of the existing fully edentulous patients actually preferred a removable implant-supported overdenture. So it's an interesting thing to be aware of. And when I'm confronted with it, the way I sell my bias is test drive the immediate load fixed. And if you don't like it, you can have a removable implant-supported overdenture.
Or maybe you should test it the other way around.
And
well, I mean, there are studies that they crossover studies where they had patients with a removable overdenture, and then they switched them to a fixed, and vice versa. And when you look at the results, that's a study done in the Netherlands. It's quite surprising. You will be really surprised to see that some patients, they prefer the removable for the simple fact that they can clean it, So I agree with you. Most of the patients will go for a fixed, and I think it's common sense. But there is evidence in the literature that patients with a good overdenture, they can still achieve a good comfort of quality of life.
Herman, do you think if that was repeated here in the United States that those results would be the same? I wonder.
I don't know. Maybe we should try.
I think maybe we should.
The reality is, though, that as clinicians, we ourselves have our own biases, and we tend to communicate our biases to our patients. I mean, I hear Ed when he says, as a surgeon, I'm biased to do a fixed type of prosthesis. But the reality is that in many patients, doing a fixed type of prosthesis is providing a disservice. And we should be all cognizant about this. I mean, a removable prosthesis on implants does phenomenally well. And, particularly, in the aging population, those patients that lose the dexterity, that they cannot do a good job cleaning. As a private clinician, I can tell you, I see these patients coming for recalls. And when they don't do a good job because they can't do a good job with a fixed prosthesis, it becomes a nightmare. And so I truly think that as a consensus, we have to have these discussions, and we have to make the patient cognizant of the why at some point in their lives, perhaps a removable appliance is going to be the best solution for them.
So
and many
Tara,
patients, many patients that do have fixed prosthesis nowadays, they will age and may have to switch to removable.
Totally.
So we have to think about that aspect as well.
Totally.
There's a question from the panel that I think maybe it was because of the way we miscommunicated what we're saying. The question is, if I have a patient who needs a white prosthesis but can't afford it, that's fine. I think when in any kind of treatment planning, and let me reverse it so it sounds a little bit dramatic, in any kind of a legal review, to see, did you commit malpractice or did you do the right thing? You look for a step-by-step procedure. And I think that's what the aim of today was. Hopefully most of you know 99% of what we said, because that means you're doing everything. It's not our opinion, it's what the literature says and what the clinical thing has been. But you evaluate the patient, their clinical crown missing tooth only defect, they require, let's say 4 implants, 6 implants, and a white prosthesis. That's like Pano said, you fit the prosthesis to the patient, right? Now you present it, then it becomes the art and STEM. You presented the science of medicine, now it becomes the art part. How do you allow the patient, or how do you treat the patient based on financial needs, based on anxiety of treatment, length of treatment, whatever the case, medical conditions like Tara presented. So I don't want the audience to think that we are saying this patient you treat this way and this one you must treat that way. No, we were saying there's only one correct diagnosis. Then you make the treatment facing that diagnosis. Then your experience and your whatever makes the variation on that treatment, obviously within parameters of what is appropriate. So I hope the person who asked that question, that clarified it for everybody. We certainly are not saying 1 + 1 = 2 every single time. The diagnosis and the treatment plan is that, but how you execute it is multifactorial.
And we will go to all the questions in the Q&A session, but I would like to ask Dr. Agalu to do a summary point before we get to that.
Absolutely. I think that our discussion has really led to this, and like what Ed just said, it's always starting at one point and ending at another. And for me, the first thing is always the medical risk factors, because you can do beautiful treatment and you can plan so many different things and you can execute it perfectly. But if the patient is significantly medically compromised or is on medications such as a parenteral bisphosphonate for cancer treatment, then your whole thing is going to potentially blow up in your face. And the number of times that I've seen that, I can't even count. So really, really be careful and identify these contraindications, whether they're absolute or relative, and discuss them all. Understand your own limitations. We've talked about the patient's limitations, whether it's their medical or their local ones or their financial ones, but what about your limitations? And sometimes we just do what we know only. And so if you need to get more training, like by doing, going into webinars like things like this, or having more hands-on training or discussion groups or study clubs or whatever, make yourself available to be able to offer all the different plans that will fit that individual patient. And I really think that that's so important. And, again, even with the studies that we've shown, and we show such high survival rates, that's just survival a lot of the time. It's not even success. And it's mostly in patients that have well-controlled situations. So when we're doing these fancy new things, or we're on the cutting edge, we're always starting with the most ideal candidates, and your patient might not be that ideal candidate. And so make sure your expectations for yourself and your patient are realistic. For sure, that's really important. And there's nothing wrong with going slowly. I have so many patients that are medically compromised that can eventually have a fixed prosthesis, a hybrid or metal ceramic or an overdenture, but I often am going much more slowly in those patients. And there's nothing wrong with that. The number of times that people come in and say, oh, I saw on TV or on the radio or on the internet that you can do all this in one day. And I say, yeah, that's if we take all of your teeth out, if you're perfectly healthy and you're, 25 years old and maybe have, meth mouth or something, right? And everything else is okay. But not everybody can have that same level and that same speed of restoration. And then not every patient is a full arch candidate, right? So maybe you start slowly. I think that one thing maybe you heard in this discussion today is that it's all about the transition, whether it's the transition from teeth to the implant prosthesis, where they started from, were they edentulous, were they not? And maybe we're going to do a ceramo-metal restoration, or maybe we're going to do a hybrid type of prosthesis. But later on, that's probably going to change. So think about how you're going to transition this patient throughout his or her life. And so with that, I think we'll end here and take questions. So thank you for that.
So before we go to the questions and while we put the next slide, and I would like the panel to give us a one take-home message each when it comes to treatment planning, and I think it's important that we all reflect our treatment planning philosophy. And starting with Ricardo, what's your take-home message for the audience, Ricardo?
I guess it's dangerous to treatment plan, only looking at a few variables. It's so multifactorial that I think we need to be very cognizant of every single nuance that is important to see as we engage with a patient in treatment plan.
Renata?
I want to say very thorough diagnosis and patient communication is critical, definitely.
Ed?
I think maybe I'm assuming we're talking about immediate loading a patient. The treatment planning is multifactorial, obviously, but one of the things that I really concentrate on is, does my patient understand? And this is what I say to them, that you can go home tonight after the treatment and eat corn on the cob. Then I wait to see, did they hear what I just said? And they get happy. Oh, I can? The answer is yes, you can, but you have to promise you won't. And somehow that little interaction clicks in their head the importance of the limited limited dietary or the restricted dietary conditions during the healing phase. So that's what's really one of the important parts for me in the initial consultation.
Waldemar?
I will say when all you have is a hammer, everything you see is a nail. So get trained, get good education, and learn all the options like Tara said and Renata said, get good information and be ready to present your patient all the treatment options, not just one because you do that one better than the others or because the budget for that patient fits into that one. So get really good education and learn how to do it. If you can treat that patient, even better. If you can't, think about doing the best for the patient. So get more tools on your toolbox.
Nicely done. Panos?
I would say my take-home message, and I would also add something. So the take-home message is, as a prosthodontist, restoratively driven planning, tooth position, smile, design is critical, and then we retro-engineer the case. And because I share similar philosophy with Ed, I will also add that the industry today is helping us reduce the cost limitation. So even if we have a tooth defect, and we will all agree that the tooth defect is about 10 millimeters, there are new types of zirconia by reducing the amount of yttria that they are strong enough, and you don't have to do this traditional ceramo-metal, heavy metal restoration, as I call them, that are very expensive. You can still do a zirconia prosthesis. You just don't have to sacrifice bone. So there are ways to treat patients without going overboard and removing too much.
And for that, they will need to tune on episode number 4
Yes.
if they want to learn all about that.
We have amazing stuff coming up in the digital approach, which are really spectacular things that the audience will see. What is currently cutting edge, and also on the episode 4, where we have digital workflow, restorative workflows. I'm excited to share.
Tara?
My take-home point would be that you always have the right to refuse to immediately load, even if you've planned to do so. So let the patient know that that's always a possibility, so that you're not apologizing after, but you're letting them know beforehand that it's a possibility.
Excellent. And I would say something that we all discuss is we started this episode by addressing the life expectancy on the US population, with this reaching 80 years old. The question I always ask to my patients, they come for a full arch restoration, is how long does that restoration needs to last? If I'm treating a 45, 50 years old patients, most likely my plan is going to be aiming for a 30-year results where data is nowhere there, right? If I'm treating an 8 years old patient, then my plan is going to be looking at probably a decade of treatment. And I think that bringing that stage of life into the treatment plan sequence is an important one. I like what Waldemar said, is that I see so many cases where we cut bone in young patients, and I'm just counting based on the life expectancy of this patient that they will need to go for another 45 or 50 years. And I think that being conservative on our treatment plan is a key factor. All right, so now we will address some Q&A questions from the audience. And I will start by seeing the questions. We have one from Jessica Allen. We expressly left the interarch distances for the prosthetic protocols, but she is insisting. I would be very interested in the numbers on the interarch relationship for the prosthesis. So quickly, Panos and Ed, what numbers are you running from the occlusal plane to the edentulous ridge?
Ed.
Is it legal to discuss running numbers on a Zoom? Just kidding. I thought that was Sunday. All right, sorry, Herman. So again, I respectfully and humbly make these numbers. The way I think about it is a tooth-only defect or a white clinical crown is 10 millimeters, right? So you need 10 millimeters if you're missing that. Now, if you have a composite defect, so you are now going with a pink portion. Well, and I'm just making this up right now because I'm trying to figure out what's the best way to explain it. So if you have a composite defect, you have a 10 millimeter tooth, you need 2 millimeters of pink acrylic on the cervical portion, or pink porcelain, whatever it is, 2 millimeters of intaglio pink porcelain or pink acrylic, and then a metal framework in the middle. So you got 10, 2, 2. So you got you got 14 millimeters right there. And then for a gold framework, which nobody does, you got 6. For a titanium framework, you can use 4 because titanium is stronger. So 8 plus 10 or so, you need about 16, 18 millimeters for a metal containing hybrid prosthesis. If you have a zirconia, then you're skipping the metal framework. So you need about a 14 millimeters or 15 millimeters. So Panos, if you said zirconia or without a framework hybrid, you need about 14 to 15, and then with something with a framework between maybe 16 to 18, would that be a
realistic number? And I will also add that at least here in Massachusetts, we have a lot of class 2 patients, and the class 2 patient is maybe the hardest to treat because you have a lot of space in the front, no space in the back. So we treat large cohorts of edentulous patients in the university and in my private clinic. And this classification of the patients are very hard because I usually have this 13, 14 millimeters in the front, but after the premolars and the molar, I get 10 millimeters. Do I still do a zirconia? Yes, I still do a zirconia. I just increase the amount of connectors, and I just, like I said, I use new types of zirconia that has really high fracture resistance, and I might go like with a molar that is 10, but still in the front I have 13, 14. So,
and also Panos, I think that when we talk about the interarch relationship, I am always propose the notion that these numbers are not fixed, because when you're treating an edentulous arch, you have a certain degree of flexibility of playing with the vertical dimension of occlusion without altering much the physiology of that patient. So in certain instances, you can, for example, increase slightly the vertical dimension and have more room, or vice versa, shorten it a little bit so you can get in a more appropriate situation.
Exactly, or play with a multi-unit abutment height.
Exactly.
A shorter multi-unit, so you get like 12 millimeters of space.
Now, Ricardo, on the same topic, Where do you draw the line between a removable and a fixed device? I think that it was very eloquently presented, but is there a clinical parameter that you say, when I see these, my first reaction is a removable prosthesis treatment plan?
Right. So normally, if you're dealing with a terminal dentition patient, if the teeth are still there, and if there's not a severe periodontal breakdown, you're going to have bone. And if you have bone, more often than not, you will be able to have teeth that will provide the right lip support. We struggle with providing fixed type of restorations when we are in their need of lip support, and we have what we call in our classifications the LTR class 3 patient, which is more of a horizontal component. I mean, granted, if we look clinically at the type of ridge remodeling that takes place, most patients are going to have a combination of vertical and horizontal. Ridge resorbs, as we all know. But there are these patients that have a very shallow vestibule, right? And they are in their need for lip support, which is what we call an LTR class 3. But with these types of patients, if we now push the envelope and provide a fixed type of restoration, and I think Panos' slide where he has a cross section where he did the duplicate of the denture, and he's showing with the probe where does it go. If you're looking at a pretty horizontal defect, that calls for a shelf-like type of solution, you're gonna that shelf is gonna be trapping plaque and food all over the map.
So basically, when you see that shelf or that anterior-posterior discrepancy,
Correct.
Between the tooth position and the ridge, the velar ridge, you say, well, now I need to either graft or do a left forward type of intervention to correct that, or a removable solution becomes my first option.
Correct.
And I think that is going to come up in the maintenance, because I personally see that the highest rate of complication appears on those patients, because on one hand, you have the ridge here and the teeth are in this position, and then you are kind of loading that prosthesis outside the support of the ridge. So I think that's a clinical, a clear clinical situation where you want to look at that.
But that's the case that you showed that you're referring to right now is a very unusual case where you have a pure horizontal AP resorption, no vertical. Yeah, those are very unusual, but yeah.
But even though, I mean, even if you were to have like a class 4, which is an extensive vertical and horizontal defect, I mean, from a maintenance standpoint, and I get it, Ed, you're a surgeon and you have your bias, and you not only are you a surgeon, but you're a phenomenal surgeon. The bottom line for us as prosthodontists, or as restorative dentists, to maintain these patients, and Panos has beautiful articles that talks about, complications, short-term and long-term complications in these patients. I mean, it's not a happily ever after. These patients present some, issues with maintenance. And so I think that at some point, having the discussion of eventually transitioning from a fixed device to a removable device, it's not that far-fetched. I think it's something that we potentially may be covering in an upcoming episode. Probably, we'll talk about digital. I can show some of the stuff that we've encountered, because I think, again, and you said it so eloquently, Ed, as well, it's in how we package information to the patient. And even Germán says, depending on the age of the patient, I'm going to plan for X amount of years. Well, some years ago, I wrote this piece on the biggest dental lie that we as clinicians incur, which is implants or implant-supported prostheses are forever. Well, there's no such a thing. And patients need to be cognizant that when they embark on a process of going edentulous, and obviously if a patient is losing their teeth, it's because of something, right? And I'm not pointing fingers, but more often than not, there's some level of neglect from the patient's end. And we should embark on being good educators with the patients. But that doesn't mean that transpires the way we'd like it to transpire down the road. And so at the end of the day, it has to be a joint responsibility, and patients need to be made cognizant about it.
Excellent. And I'm going to take one more questions, and then regarding the number of implants, and I want to ask Waldemar to take this one. So we all know that you can restore an edentulous arch with 4 implants, whether they are tilted or anterior posteriorly distributed. Now, if you had a choice or bone availability, right, to place more implants, which is this is often the case. I ask the question: is are 4 implants the bare minimum, and are we treating those patients without a margin of error or without a safety net? In other words, you lose 1 implant and the patient goes back to an overdenture.
All on 4, none on 3. But, you know, this is a good point of discussion because there's so many factors involved. If I have enough bone, I want to put 8 implants and do 4 segmented 3-unit bridges with all white teeth. My clinical experience that I actually grafted many patients to give them that choice. You know, you've seen my presentation from 15, 20 years ago. I have many patients that actually did a bilateral sinus floor elevation, anterior horizontal graft, and to build the bone in a restoratively driven bone augmentation, it takes a year. It's more risk, it's more expensive, but that would be the ideal reconstruction because you're rebuilding bone to perfectly position your implants according as close as possible to where the teeth were one day. And of course, like I think Ricardo mentioned, the maintenance. The patients lost their teeth and now we're placing implants and think that they will last forever. So if there's another tying to your thing, your question, there's a good question on the Q&A here that talks about how about short, wider implants on the posterior maxilla. So that's again, we discussed that in our team here at IU, you know, kind of a daily basis. Do you like tilted implants or you want parallelly placed implants? It took me more than 10 years to learn how to place my implants in a very nicely parallel fashion. And now the tilted is the go-to. For me, implants have to be parallel, number 1. If I cannot do them parallel and with a nice distribution, then I'll think, what are my choices? Grafting or tilting, right? So if I have good width on the posterior maxilla, and I have 5 or 6 millimeters of bone height, maybe I'll do an osteotomy and put an 8. Dr. Panas here did a really nice systematic review showing the evidence that 6 and 8 millimeters implants work. If you have to put a 4, no, maybe I'll think, because we know that tilted implants probably have higher survival rates than the 4 millimeter. They have to be splinted. What is the opposite arch? How, you know, we're not doing immediately loading on transalveolar sinus floor elevation with a 6 millimeter implant, so they have to wait. But we have done 6 implants in the maxilla with the 4 anterior implants are immediately loaded, and we do not load the posterior ones. So we do a short immediate prosthesis provisional, and then 3 months later they come and then we splint all the 6 implants and we have better distribution. So I would say if I could for the maxilla, 6 implants would be my choice for a hybrid splinted all implants. If I have a lot of bone, if I ever one day lose my teeth, I want 8 implants and I want a 4 3-unit segmented bridges like you have published, Hedman, in your papers. But if I get a patient that you know is medically compromised or I want to be minimally invasive and I want to immediately load, we know that 4 implants with the 2 distal ones tilted work just as well. For the mandible, 4 implants are okay. There is long-term evidence on it. If you have enough bone and you want to splint the prosthesis, canine to canine, premolar to molar, you go with 6 implants and you do a segmented arch. So, of course, there are costs involved, and you have to, like we discussed, this patient's age. So what is going to happen 20, 25 years from now when we do these implants in a 4-year-old? Are we transitioning, or are we changing it back to removable? If they have bone loss, if they have periimplantitis, whatever happens, you know. So tissue stability is very important, and occlusal care, occlusal load has to be really well distributed and think long term. So there's no right or wrong. It's just each patient is one.
I thank you all for your fantastic contribution to tonight's episode. I also thank you, the audience, to the more than 300 participants that stayed until the end of this presentation. In the next episode that will take place on March 9th, 2011 at 7 p.m., we will address the digital approach to a full arch implant rehabilitations with Dr. Renata Camino, Ricardo Mitrani, and Panos Papaspiritakos. You will have the latest and the most advanced presentation on digital approach for full arch implant rehabilitation. For now, thank you very much for joining us, and we'll see you all in March, on March 9th, 2021.